I would like to start with this gentleman who lived in the 19th century, who did a seminal statement, which is atherosclerosis is a chronic inflammation induced by cholesterol. And this was not clear at that time, but it was visionary indeed. And today we would say that if you look through a vessel wall like here, it may be a bit complicated, but in fact it's not. You can see that lipids accumulate between the endothelium, which is the inner layer of the blood vessel wall, and the smooth muscle cells, which are the muscles that dilate and constrict the blood vessel. And they induce a lot of inflammatory events that lead to the adherence of white blood cells, and then a plaque does develop here in the vessel wall. And when we look at what cholesterol really does, and we plot this in a logarithmic scale, you can see there's a linear relation. The higher the cholesterol, the more infarction and coronary disease and events. So this is very, very solid data that cholesterol is extremely important. And Charles Darwin, a great Englishman, said he who understands baboon would do more towards metaphysics than Locke. And so I did. I looked at these guys, and we looked at LDL, cholesterol, in different animals in evolution, if you want. So there's the mouse, there's the rat, and so on, up to the monkeys. And here is the LDL cholesterol, the low-density lipoprotein cholesterol, which is the bad guy that causes atherosclerosis. And as we moved upwards, we also moved upwards with the LDL. And you can see that the humans, they're all hyperlipidemic. They all have hugely elevated cholesterol compared to all other animals. And no dog would die of a myocardial infarction. No rat or mouse would do so. And in fact, humans are the only species in evolution that have extremely high LDL cholesterol levels, and the only species that dies of myocardial infarction. And so that's what it is. As in the mouse, if you want to have atherosclerosis in a mouse, you have to genetically modify them to develop plaques. So difficult is it to achieve this. And in fact, I have never seen a chimpanzee in an emergency room with a STEMI as his LDL is below 1 millimoles per liter. It's very, very low. Okay, so let's go back. Is it just our bad habits? Is it McDonald's? Or has it been with us for decades, for years, for thousands of years? And this is a gentleman that you can watch in the Egyptian Museum in Cairo. And he lived 1213 before Christ. And if you put these guys in a CT scan, I mean, they're mummies, not really living, of course. They're not, the life expectancy was not as splendid at that time. But you can see that the coronary arteries of mummies that have died 5,000 years ago, they already have severe calcifications of the right coronary artery or of the anterior left descending coronary artery. So coronary artery disease is a reflection of atherosclerosis of the heart vessels, and it is a typical human disease. And there are lots of researchers that looked into this. Brown and Goldstein got the Nobel Prize for showing that the LDL receptor that takes up the LDL in the liver, the bad cholesterol, is the culprit. And then there were two ladies from Paris, Catherine Boileau working with a gentleman from Canada, that showed that also other proteins are involved in regulating how high our LDL really is. And this is interesting. So these are the LDL receptors. They pick up the LDL, the low-density lipoprotein cholesterol, because cholesterol is a fat. It has to run with a protein, otherwise it's not water-soluble. That's why we have this big corpuscle. And then the LDL receptor takes it up and digests it. And the more LDL receptors you have, the better you're off, because then, of course, it clears the blood from all the bad guys that you don't want to have. And there's another protein, I don't know why nature invented this. It's called PCSK9. It's a very long name, we don't have to remember that. And this protein is released and it actually gets rid of the LDL receptors. So it's a bad guy as well. The more PCSK9 you have, the lower the number of receptors, the higher your LDL in the plasma. And so these searchers from Paris that I showed you, they showed that those who have very high cholesterol, they either have LDL receptors mutations that leads to a very low number of these receptors, or they have a lot of this protein that gets rid of the LDL receptors. And so this is very interesting because they looked at this protein or the gene of it, PCSK9, and what they showed is in the Afro-Americans that have a mutation in this gene, which produces a dysfunctional protein that does not get rid of the LDL receptor. So they have lots of LDL receptors. They have very low LDL compared to the American population. And compared to the Americans that they're very good at dying of coronary disease, these guys are protected. They live forever almost and have no infarction. So this missense mutation, as the geneticist called it, is very protective, and this led through drugs, as I will show you in a moment. This is a bit of a complicated slide, but here it shows how much exposure to LDL you have. The higher it is, the worse it gets, because here are the events like death, myocardial infarction, and stroke. And the more exposed you are to LDL, the more stroke, myocardial infarction you have. And what you can see is if you have a mutation, this is our Mendelian randomization studies. Mendel was the discovery of the genetics. And so they look for people that have this mutation of a gene that produces lots of PCSK9, bringing down the LDL receptor, have very high cholesterol levels. They have lots of events. And those who have a missense mutation that have very low levels from birth, then they have very low levels of events such as death, myocardial infarction, and stroke. And here these are the trials. And why is it that the trials with statins that are so much in the media are worse than the genetics? It's very simple, because you can see here that the trials go for 2 to 5 years, and the Mendelian randomization studies, they go for a lot of years because it's from birth. So if you're 50, oh God, if you're 50, very unstable situation. If you're 50, then you didn't have LDL from birth. But if you're 50 and you start to take a statin, you already have plaques. So this is why this is less steep a curve. Okay, but of course there are also differences between different cultures. You can see here that, for instance, in Northern Europe, the Finns and the Brits, they have a lot of coronary disease, while the Japanese are the best. And why is this? Because, of course, you can say it's the genetics. Of course, they may differ genetically. The Japanese, they already look different than we do, so they are different genetically. There may also be that the LDL receptor regulation is different. But then if you look at the Mediterranean countries, they eat a lot of Mediterranean food, olive oil, and so forth. And the Japanese, they eat fish like crazy until it pours out of their ears. So they are protected from coronary disease. So there is a modulation, and that is what you can do when you change your lifestyle. Okay, but so let's look at these guys. And we are still genetically like these guys. And, you know, if you look at politics, we haven't really made a lot of progress. But daily exercise was a must there, because they had to fight to get food. They had limited food. They had famine periods, and then they had hunted an antelope and had food for a lot of time. They had no fridge. They had to eat it immediately. So it was a completely different way of eating. Intermittent fasting. They were omnivores, of course, and there was no alcohol. Okay, so let's look at how they are today. These are guys that live in the Amazon in Bolivia, the Tsimane Indians, and you see they are not very developed in their weapons yet, fortunately enough. And they actually looked at these guys, they took their blood and they put them even in a CT scan. And what is very interesting is, first of all, their blood pressure is very low. You would think that their life is quite dangerous. You know, they may meet a jaguar while hunting, which is an unfriendly encounter. But no, their blood pressure is actually very low, even if they get quite to an old age. And secondly, their LDL levels are much lower than ours. It's about 2.5 millimoles per liter. Here is about, on average, 3 to 3.5. So there is a cultural effect. It's not just the genetics only. So what does all this mean for coronary disease, stroke, and death? Well, if we have hypertension, diabetes, hyperlipidemia, and smoking all together are particularly bad, you get these plaques. And then, of course, the arteries get obstructed. If they get obstructed, there's not enough blood for vital organs such as the brain and heart. Here you get a stroke, here you get angina pectoris, or you get an infarction, you may die, or you get heart failure because the heart is damaged and gets bigger and bigger. And a big heart is only good in poetry, not in real life, because it actually limits your life expectancy significantly. So coronary artery disease, the symptom is what we call angina pectoris. It's chest pain. And it comes either upon exertion when you go up the stairs, and it may be associated with ECG changes if you do this on a bike and the doctor actually runs an ECG, and it's due to a narrowing of an artery, as I will show you. If it's at rest, this pain, then we call it an acute coronary syndrome, which is just a new name for myocardial infarction. So it's typical chest pain. It's here, it radiates to the arm. It shows enzymes from the heart like troponins, ECG changes, and it's usually a narrowing or an occlusion of a major coronary artery. So let's first look about unstable coronary disease. This is another important Englishman. It's William Heberdine, and he described exactly how it is. It's really excellently written. There is a disorder of the breast, marked and peculiar symptom, considerable for the kind of danger belonging to it, and not extremely rare, of which I do not recollect any mention among the medical authors. So he's the first one to describe that. The seat of it is, and the character is strangling. So it goes with anxiety, and when they stand still, the moment they stand still, it disappears. So this is really everything what you have to know. It is chest pain that comes with exercise and disappears when you stand still. This is stable angina pectoris, and that's how it looks like. This was a lady that while jogging, no wonder, got chest pain, and then we put in a stent, and now we can see the difference. The artery is now, of course, open. And this is how it would look like when you look at it. This is the whole area that's blue is not well perfused, while the area that's red is well perfused. So this is the artery open, and on the other side it's not. Unfortunately, I cannot do it well with this computer. But anyway, what can we do? We can give medication. We can get a stent, percutaneous coronary intervention, that's how we call it, or we can do a bypass surgery. And optimal medical therapy is a lot of drugs. These poor guys, they have to take a lot of drugs, as I will show you in a second. For symptomatic treatment, to treat angina pectoris, we can give nitrates, calcium antagonists, beta blockers, ivabradine, nicorandil, ranelozine. These are the drugs to treat the pain. If we want to make them live longer, we want to inhibit the platelets with aspirin that you all know, and then there are other drugs like clopidogrel and others that are given for those who have a stent in particular, but sometimes maybe also for others. We can reduce the heart rate, then the pain gets develops later. And we can also treat the lipids, as I've shown you. The lower the lipids with these 3 drugs that are currently available, we can lower LDL so that it doesn't get worse. But this will only affect the event rate, how much stroke, myocardial infarction, and deaths you have, but not the symptoms. And I will skip this in the interest of time. But what I would like to show with the new drugs, when you measure the diameter of the plaque in a coronary artery, it can grow or it can regress. And today we have, if we really go down with LDL cholesterol, we can actually regress the plaque for the first time in medical history. And you can see that if we get below 1.4, not quite to the chimpanzees, then we start to get regression, because otherwise atherosclerosis is progressive in nature, and that's why it is so dangerous for the patients. And you can see that even with the most modern drugs, like these PCSK9 inhibitors that inhibit this protein that I showed you, there is still in 36 months or 3 years, 1 out of 12 patients has a myocardial infarction, stroke, or dies. And this is true for both new drugs that we have. Placebo means that they take a statin and another lipid-lowering drug. So this is a progressive disease still, and we have to work on it to make it even better. What's very important is the lifetime risk. So what they usually show you is the risk that occurs in 5 years. 5 years are usually the trials. But basically, if you ask the doctor, what does it mean for my entire lifespan, you can see it's enormous. If you're a smoker that has diabetes, hyperlipidemia, and has hypertension, your probability of dying in this time frame is almost 50%. And if you have none of it, it's much less. Unfortunately, even then, there is a risk, because life is a chronic disease with a fatal outcome, as you know. Okay, so let's look at the next one. That's percutaneous coronary intervention, and where I worked before in Zurich, Andreas Grünzig invented this, and hopefully we can run no, it doesn't run, but you can see here that's again a narrowing here. Can you see it? And then we blow up a balloon in this very instance here, and then when the stent is placed, the narrowing is completely gone, and the artery is much bigger because it fills with much more blood. So that's the technique. It started with a balloon. Then the stents were invented. They also created a lot of problems initially. And then we had stents that have a drug on it, a drug that inhibits the scar formation, and they improved our outcome markedly. And eventually, maybe we will come up with drug-eluting scaffolds that digest, that the body digests within a year or two, and with lactic acid. This has already been used in patients, but unfortunately the results are still not so good like with the metal stents, but we will hopefully see this in the future, because then it would be only a transient scaffolding, like building a house, and then once the house is done, you remove it. Okay, so this is a bit of a complicated slide that I prepared mainly for the physicians among you, but it shows do stents provide symptoms relief compared to the drugs that I showed you. And what we can see, if it's on this side of the line of identity, these are different studies, then there is relief. And you can see most studies have shown that there is symptom relief with stents that are better than just medical therapy. And that's also our clinical experience. However, unfortunately, all-cause death was not altered in stable coronary artery disease, unlike infarction that I will show you later on. But it seems that there are less, with a stent, there are less revascularization. That means that you don't have to go again to the hospital to have another intervention. So PCI or stenting in patients with stable coronary disease does work. It improves symptoms. Outcome is less certain. And here comes, of course, the bypass surgery. Bypass is a bit more complicated. You have to stay in the hospital for longer periods of time. They have to open the chest, and then they put a bypass, either a vein or an artery that you can see here, bypassing the narrowing of the coronary artery. And here we can say that a bypass surgery is indicated when you have all three coronary arteries affected, if you're a diabetic, and if you have left main disease, that is the left coronary artery. But of course, that's why I put it in bracket, is still under investigation. So I leave this out because it's a bit complicated. Now this one, now we move to acute coronary syndromes. That is acute myocardial infarction. And there the situation is much different. Acute myocardial infarction is a deadly disease. And in the old days, when Eisenhower had his heart attack in 1955, 1 in 2 of the patients even reaching a hospital, and not many did, died. So this was a very, very bad disease. And today we know that this is chest pain at rest, typical chest pain. The heart enzymes are elevated, ECG is changed, and usually it's occlusion of a coronary artery. And that's how it works. This is 30 years in a nutshell. You develop your plaque, and of course this is due to low density lipoprotein. Then you may have stress, spasm, or get up the stairs, and then plaque may rupture. The blood thinks that there is a hole and makes a thrombus, and boom, the artery is occluded. This is a infarction, and it usually has a very, very high mortality if not treated immediately. So why does it occlude an artery? And the reason is that there is an inflammatory burst. And you can see here, this is interleukin 6. This is an inflammatory cytokine. It's hugely elevated here. And that's why if you have an infection, if you have an operation or any other inflammatory stimulus, you can have a myocardial infarction. And you can see when we remove with this catheter here the thrombus, you can see this is what occluded the coronary artery in this particular patient. So it's a huge thrombus, and we can look at it under the microscope, and we see that it has blood platelets, it has fibrin, but it has also white blood cells. So there's a lot of inflammation occurring at the site of a coronary occlusion. And this is the last 50 or 60 years of development in cardiology. And you can see this is when we had nothing. And about 1 in 2 patients died of myocardial infarction. Then they introduced defibrillation, because one of the deadly consequences of myocardial infarction is an arrhythmia called ventricular fibrillation, where the heart just fibrillates, does no longer pump. You give him a shock, an electric shock, and he gets back to rhythm. This already created a huge improvement in the survival of patients with acute myocardial infarction. Another Englishman, Sir James Black, invented a beta blocker, propranolol, that further declined mortality. Then came coronary angiography and stenting of coronary occlusions, and this made a huge difference. You can see down to 25%, and then there are new drugs that were introduced to inhibit platelets and the coagulation, and today we're around at 10% mortality, so it's a huge improvement, a 5-fold improvement in survival compared to the old days. Now here we are a bit flat, as you can see, and the reason is that shock, cardiogenic shock, that these are patients have a very severe infarction and come with low blood pressure, loss of consciousness, or even have been resuscitated. There the mortality is still high, and here we have to work on it. But after myocardial infarction, you are a patient for the rest of your life, because you have to take statins, cholesterol-lowering drugs, maybe another cholesterol-lowering drug, and in the future maybe even these new but still expensive drugs. For inflammation, we have statins also. They are a bit anti-inflammatory, but we have no good drug for that at the moment. Then for for the thrombus that I showed you, we have aspirin and clopidogrel mainly, but there are newer ones that are currently used, like ticagrelor and others that are tested. Then, of course, the triglycerides. If you're diabetic, you have not only LDL cholesterol, you have also triglycerides. And so that's also important that you take some fish oil or something else. And then there are new drugs for the lipoprotein A, the PCSK9 inhibitor that I showed you, but also new genetic tools, antisense technology, where you can actually switch off the genes. And finally, for diabetes, there are now new drugs that actually prolong life in diabetics, such as empagliflozin or other drugs. I'd like to just end up with a new perspective, and that's the gut microbiome. Did you know how many bacteria inhabit the human body? It is 100 trillion bacterial cells. So we're full of bacteria, and 37 trillion cells make up the human body. So we have 3 times as many bacteria in our body than we have actually cells that make us up. And these bacteria, the bottom line is they eat what we eat. What we have in the stomach, they eat what we eat. So if we eat a lot of eggs, cheese, steaks, then they love it, and they form from some of the products such as carnitine or phosphatidylcholine from meat, let's say. They form choline, they put an amino group on it, it's TMAO called, and in the liver we actually oxidize it and we end up with trimethylamine, and this is a bad guy that comes from this sort of diet, and we have tested this in Switzerland and the Americans. The Americans have much higher levels of those because they eat scrambled eggs in the morning, cheese, and then steaks in the evening, or even lobsters, and they have lots of it, and they die much more of coronary disease, as you know. And when you have a lot of this TMAO from this particular diet, your likelihood to die is much higher than if you don't have this. So watch what you eat, and rather have white meat than red meat, because these are the red meat eaters and these are the white meat eaters. Okay, so let me finish by saying that everything became extremely complicated these days. This is the genome that we have and that you're born with. And some make the first mistake by selecting their parents with some genetic mutations. Some are more lucky and got the right choice. And then, of course, you get proteins, and these make up an organ such as the coronary artery. And this is also, regulated by so-called microRNAs and long-coding mRNAs. That's very, very complicated. And in addition, these genes and their transcription into proteins is affected on whether you have diabetes, blood pressure, whether you smoke or not, and what you eat or not. So it's very complicated. We will never understand this. So we need actually machines to help us. And I think in the future, we will have, for the genetics, we will have machines that calculate a risk score that integrate any imaging we have from us, like a CT scan or an angiogram. And also, when we are in an emergency situation, they will collect all the data and help the physicians to reach the right decisions also in the clinic as well. So this will change, of course, and add to our knowledge, because we cannot figure out more than 100 parameters in a reasonable fashion. So I will skip this in the interest of time, but I would just say that this is a seminal paper that opened the door, a Pandora door, if you want, and they, for the first time in human embryos, changed a gene that causes a muscle disease of the heart called cardiomyopathy, and produced healthy embryos that initially had this disease genes for hypertrophic cardiomyopathy, and were able to, with a scissor, a genetic scissor called CRISPR-Cas, to cut it out and to get a new gene in. So this is a future of gene therapy that maybe will change medicine in the long run. And you can see this is the cycle of life of atherosclerosis, And you can start here by treating your blood pressure, you're treating your lipids, and then you will avoid, at least in part, stroke, myocardial infarction, heart failure, and death. And we made a lot of progress, as I showed you, but there's lots of course, to do, because the mortality rate is still much higher than it should be. And for that, we need research that at Imperial is done at a very high level. Thank you very much for your attention.